Good morning. So today we'll be discussing about the topic clinical diagnosis, specifically in case of periodontics. The contents will include the following things: overall appraisal of the patient, health history, dental history, photographic documentation, clinical examination, tactile periodontal examination, periodontal charting, examination of the teeth and implants, radiographic examination, laboratory aids to clinical diagnosis, periodontal diagnosis, assessment of biofilm control, and patient education. So, coming to overall appraisal of the patient, from the first meeting, the clinician should attempt an overall appraisal of the patient. That is, we should be able to judge the patient's mental and emotional status, temperament, attitude, and physiologic age. In case of health history, most of the health history is obtained at the first visit, and it can be supplemented by pertinent questioning at subsequent visits. The health history can be obtained verbally by questioning the patient and recording his or her responses in the patient chart, or by means of a questionnaire that the patient completes prior to the appointment. The health history should include the references to the following important points, which you can read in detail and should not be omitted at any cost. In case of dental history, it will include the history pertaining to the chief complaint as well as any current illness. And the dental history should include the references to the following things. It includes visit to the dentist, should be listed, the patient's oral hygiene regime, any orthodontic treatment, if the patient is experiencing any pain in the teeth or in the gingiva, you should be noting the presence of any gingival bleeding, any bad taste in the mouth or areas of food impaction. Should assess whether the patient's teeth feel loose or insecure. Note the patient's general dental habits such as grinding or clenching of the teeth during the day or at the night. Discuss the patient's history of previous periodontal problems. Note whether the patient wears a removable prosthesis. Does the patient have any implants to replace, any missing teeth? All these things are given in a common layman term so that it is easy for patient to respond to your questions. After doing your dental history, we move on to the photographic documentation. Initial photographs should be taken before the tissue is probed and manipulated to obtain an undistracted baseline of patient's mouth, gingiva, and biofilm intact. Digital photographic documentation is important and useful for record keeping, education of both the clinician and the patient, communication with your references and colleagues, and planning and treating of high aesthetic demand cases. So this is an example of the documentation that should be done routinely in all cases. The first one is the periodontal image of the frontal view, and the remaining 8 images below are the intraoral pictures using mirrors which are taken on the frontal, lateral, buccal, palatal views. After your photographic documentation, we will go to your clinical examination. In clinical examination, we start with extraoral structures, that is temporomandibular joints, muscles of mastication, lymph nodes. After doing your extraoral examination, we move on to the oral cavity, where you should examine the oral hygiene of the patient, any oral malodor, the lip, the floor of the mouth, the tongue, the palate, the vestibule. The oropharyngeal region should be evaluated for abnormalities and pathologies. The oral mucosa in the lateral and apical areas of the tooth may be palpated for tenderness to detect periapical and periodontal abscess. Once we finish with oral cavity, we zoom in and go to examination of our periodontium. This includes visual as well as tactile examination. In case of visual periodontal examination, we look into to check the biofilm, calculus, clinical signs of any inflammation, recession. Following that, we also see gingival margin and the gingiva as such. So when we look at the patient visually, we can see these clinical presentations in case of an inflamed gingiva. Moving with the tactile periodontal examination, we look for consistency, marginal bleeding or separation. The gingival crevice is then probed to evaluate the subgingival environment. The tooth surface is carefully probed for any abrasions, concavities, furcation, subgingival calculus. The response of the gingival tissue to probing is appraised in terms of resistance to probe penetration, depth of probe penetration, bleeding on probing, and pain on probing. So this is an tactile examination wherein purulent exudate is expressed from the pocket. So here the picture A is a normal sulcus where the probe penetrates about 1/3 to half the length of the junctional epithelium. The picture B depicts in an inflamed periodontal pocket, the probe will be penetrating beyond the apical end of the junctional epithelium. It is stated that the biological or the histological pocket depth is always shallower than the clinical or probing pocket depth. The absence of bleeding on probing is an excellent predictor of periodontal stability. Clinical attachment loss measures how much attachment loss has occurred using cemento-enamel junction as the reference point. In case of clinical attachment level, it measures the distance between where the periodontal attachment apparatus begins coronally on a tooth and a fixed reference point. So for example, to understand, we need 3 points to be remembered. The first will be the free marginal gingiva, which is in the pink arrow. The second point is the green arrow, that is the cemento-enamel junction. The third point is your base of the pocket. So we should remember these 3 points. In case of clinical attachment loss, we are aiming to measure the distance from cemento-enamel junction to the base of the pocket. Usually when we probe a sulcus, we will be measuring your periodontal pocket or gingival sulcus depth. That is going to be the measurement from free gingival margin to the base of the pocket. Will be usually measured when we are going to probe. So based on that measurement, we are going to differentiate the clinical attachment level or clinical attachment loss in case of normal gingiva, in case of where there is recession, where there is gingival enlargement. So normally we can measure the distance from the free gingival margin to the pocket depth, and then later on you should measure the distance from the free gingival margin to the CEG. These two distances are also important so that we can get the point CEJ to base of the pocket. I will explain that in detail in your next slide, wherein the first condition, as you see in this picture, there is recession. So the two measurements that we are going to measure is pocket depth first. So pocket depth will be measured in this case from the free gingival margin to the base of the pocket, which they have shown it as 7 mm. The second value will be CEJ to the free gingival margin. So that is given as 2 mm. So in case of recession, the clinical attachment level, which is actually the measure from CEJ to the base of the pocket, in case of recession, will be addition of the CEJ to free gingival margin plus free gingival margin to the base of the pocket. That is 2 plus 7. That will be the clinical attachment loss. In case of gingival overgrowth, the same values, it should be subtracted. That's the only difference. Again, free gingival margin to the base of the pocket, you should get one value, that is 7. Then you should also measure free gingival to CEJ. That value is actually not given in this picture. So try to understand. We are measuring the whole pocket depth from the free gingival margin to the base of the pocket as 7 mm. And then we actually want to obtain CEJ to the base of the pocket, which is clinical attachment loss. So that value, which is as 5, it is given, that is obtained by subtracting 7 from free gingival margin to CEJ distance, that is 2, which is actually not shown in this picture. Actually, free gingival margin to CEJ can be measured by probe. That should be 2 mm. So when we are going to subtract 7 and 2, you will be getting 5, which is CEJ to base of the pocket. I hope it is clear. If you have any doubts, you can anytime contact me. After measuring your basic values, we will go to periodontal charting. The chart to record the periodontal and associated findings provide a guide for a thorough examination and record of the patient's condition. They are used to evaluate the response to treatment and for comparison at recall visit. So these are the following things which has to be recorded in your periodontal charting. It is gingival index, sulcus bleeding index, pocket, determination of the disease activity, alveolar bone loss, furcation invasion, periodontal abscess. So this is the periodontal charting chart, which is beautifully you can assess the condition of a patient. The first picture in this shows bone sounding, wherein under local anesthesia, the probe is inserted down to the bone and then walked along the tooth to explore the bone architecture. The second picture, wherein you can see the difference between the correct probing method for exploring the bone architecture. The first picture shows vertical insertion of the probe, which may not be helpful in detecting the interdental craters. The second picture, which the way actually you should do, that is the oblique positioning of the probe to reach the depth of the crater. After doing that, we are going to the examination of teeth and implants. These are the following things which you should examine. That is the wasting disease of the teeth, dental stains, hypersensitivity, proximal contact relations, tooth mobility. In tooth mobility, concentrate whether it is because of periodontal inflammation or attachment loss or because of any occlusive trauma. Then we should look for trauma from occlusion, pathological migration of the tooth, sensitivity to percussion, dentition with the jaws closed in order to check for irregularly aligned tooth which may favor plaque accumulation. Last, we should look for functional occlusion relationships. So this is a picture showing your non-cavus cervical lesion, which are attributed to combination of abrasion, abfraction, and erosion. This is a flat, shiny, discolored surface produced by occlusive wear, nothing else than attrition. Clinical picture of that. And this picture depicts tooth mobility, which is checked with a metal instrument and one finger on the other side. And this is a picture for showing pathological migration, that is, there is facial flaring and supraeruption of the right central incisor and spacing between the laterals and the centrals. It's because of chronic periodontitis, actually. Moving on with radiographic examination. The radiographic survey should consist of a minimum of 14 intraoral films and 4 posterior bite-wing films. And then you should add on with panoramic radiograph, which are a simple and convenient method of obtaining a survey view of a dental arch and the surrounding structures. So this is intraoral IOBs. And then this is the OPG, which will give you an exact, easy way to clinically diagnose your periodontal patients. After that, we move on with laboratory aids to clinical diagnosis. When unusual gingival or periodontal problem are detected that cannot be explained by local causes, the possibility of contributing systemic factors must be explored. So for that, you need to investigate blood investigations, urine analysis, serological analysis, and biopsy may be required in some cases. After that, coming on to periodontal diagnosis proper. Once the patient history has been obtained and clinical, radiographic, and other necessary examinations have been performed, the information required is synthesized and interrupted to answer 3 basic diagnostic questions to derive the periodontal diagnosis. What are they? What is the disease? How severe is the disease? What is the extent of the disease? Disease that can affect the periodontium are listed in the classification of periodontal disease and conditions. That will be dealt later in some other presentation. Then we come on to the severity of periodontal disease. It is classified based on 3-tier system. That is, one is the slight, mild, early, initial or moderate, and then it is severe or advanced. The extent of the disease is classified as generalized or localized. When localized, the extent can be specified to the quadrant, teeth, or even the tooth surface. Diagnosis of biofilm-induced inflammatory periodontal disease is based on the presence of periodontal inflammation and attachment loss. Severity of periodontitis is characterized based on the clinical attachment loss. So this following table will help you for the basic Diagnosis. In case of healthy gingiva or pedontium, there will not be any inflammation or attachment loss. In case of biofilm-induced gingivitis, there will be inflammation, but there will not be any attachment loss. In case of chronic periodontitis, you will have both inflammation as well as attachment loss. And we have one more criteria where the pedontium is healthy, but with a reduced pedontium, that is, with a history of chronic periodontitis. In such situation, there will not be any inflammation, but there will be attachment loss. So keep this table in your mind before diagnosing a periodontal case. Then the most important thing is the assessment of biofilm control and patient education. Under this, the patient should be given personalized oral hygiene instructions to control biofilm and to improve their oral health and the conditions of the periodontium. The effectiveness of the patient's biofilm control must be evaluated. The patient should be asked to demonstrate biofilm control, that is, toothbrushing or flossing, in front of a mirror so that both the patient and the clinician can see his or her oral hygiene techniques. The patient should then be taught proper biofilm control technique with a demonstration in his or her own mouth in front of a mirror. So coming to the conclusion, the examination follows diagnosis, prognosis, and treatment plan. Here, as you see, examination, diagnosis, and prognosis has one-way arrow, but treatment plan and prognosis has a two-way arrow. Why? Let us see. Diagnosis requires thorough and careful examination. Prognosis is based on accurate diagnosis. Treatment decisions are based on prognosis. Then treatment decisions are made to improve your prognosis. So diagnosis and prognosis will change your treatment plan. Your treatment should always improve your prognosis from poor to fair and good. That is how a treatment plan is done. So I hope it was clear for you and it has given an overall flow chart for how to handle a perio case when you enter into the department. And this is just the basics so that you can have an idea of how to examine, diagnose the case based on the prognosis. And the prognosis should be treated in such a way that it improves. Thank you.